This week on the BackTable podcast.
Yeah. Over and over, we've seen that these technologies are first and foremost safe for our patients.
The difference with like serration angioplasty is you don't really need to go to high atmospheres, right? So the balloon itself too, like, I mean, you can do very low atmospheres, like 5-6 atmospheres, and really get good luminal gain. And I mean, most people don't need to max it out at 10 atmospheres. So it's a low pressure angioplasty, and the serration is doing the work, right? That's all that point force is being applied across the lesion. So I think that's important to understand that, you know, we're not trying to do high pressure angioplasty. You get a balloon rupture, then you end up with a perforation.
For patients with complex PAD and CLI, durable outcomes start with smarter therapy. The Serenator combines balloon angioplasty with serration technology to deliver reliable lumen gain while minimizing recoil and vessel trauma. Clinicians report a low bailout stent rate even in calcified or tortuous lesions, which is necessary for vessel prep or standalone therapy. Serenator's targeted, controlled approach prepares the vessel more effectively, minimizes recoil, and reduces reinterventions. If you're aiming for more predictable, durable results, it's time to take a closer look at Serenator. It's time for a new standard of care. Learn more at CagentVascular.com.
I'm your host, Sabeen Dhand, and today we're diving deep into a topic that's fundamental but often under-discussed: vessel preparation. Whether you're dealing with calcified fempops, tricky BTK lesions, or tackling ISR, your success often hinges on what you do before you even open up a regular balloon or stent. We're talking all things atherectomy, specialty balloons, specialty devices, what to use, when to use it, and why it matters. We've got two amazing guests today, Dr. Jay Mathews and Dr. Michael Siah, to educate us on all their strategies for vessel preparation. Welcome, guys.
Hey, thanks for having us.
Yeah, it's awesome to be here.
Thank you. Thanks for being on. I mean, you know, for our audience, whether you're a minimalist, a maximalist, or somewhere in between, you know, we've got a great convo on building better foundations for better outcomes. Jay, you've been on the show many times. Michael, welcome aboard. Really excited to have you on. Can you kind of just introduce yourself to the listeners, kind of where you're at, Michael, and where what your practice is like, and then Jay, you can follow with yourself too.
Yeah, thanks, Sabeen. I said this earlier. Long-time listener, first-time participant. Jacked to be here, but my name's Mike Siah. I'm a vascular surgeon. I practice in Dallas, Texas at UT Southwestern. I'm the director of limb salvage here, and I work in, you know, a university hospital setting, and then I also work in a private hospital setting. And I'd say, you know, 80 to 95% of my practice is dedicated to patients with critical limb-threatening ischemia. So I'm doing a lot of lower extremity interventions, and I'm thinking constantly on how I can make my algorithm better to get the best outcomes for these patients.
Nice. And sorry, how long did you say you're in practice?
I've been done 6 years so far.
Awesome. Jay, what about you?
Hi, I'm Jay Mathews. I know you guys have seen me before, but I'm an interventional cardiologist focusing mostly on the endovascular space, and I'm based out of Tampa Bay. And I've been in practice out here for about 20 years, and you guys know me as a new technology junkie, so work with a lot of companies with device development.
I love it. Yeah, we got some nice representation here, you know, across the U.S., West Coast, East Coast, everything in between.
That's right.
All right, guys, one of the things, you know, I just wanted to open up, I mean, vessel prep, we could talk days on, you know, 100 different devices, right? But being a technology junkie, Jay and Michael being, you know, 6 years out, I mean, how has your practice, how has your approach to CLTI case, how has it changed in the past 3 years? And by that, I kind of mean, you know, are you doing more imaging? Are you opening up more devices? And with this vessel prep, I mean, are you doing more or doing less? Mike, what about you?
I'd say when I think about over the last 3 years, I wouldn't say that my practice has changed too much, because I think I've always been somebody who's willing to get more information or do something different. I think conventional angioplasty, just straight up PTA, is the same thing people have been doing to treat blood vessels since the 90s, right? So from that perspective, I've always been trying to do things, you know, very different to historical precedents. 3 years ago, I was using a lot of intravascular ultrasound. 3 years ago, I was using a lot of specialty balloon technologies. And 3 years ago, I was using drug-coated technologies where they were available. I think the only couple of things that are brand new to me in my practice in the last 3 years would probably, you know, be the use of a bioresorbable scaffold below the knee, and up until very recently, having access to retrievable stent technology, right? So specialty scaffolds for the BTK space. But apart from that, my practice hasn't changed too much.
In your training too, were they also pretty, you know, involved in doing specialty devices, or was it more POBA and possible Barostat?
I think that the practice where I trained, so I trained at MedStar in Washington, D.C., and I was really lucky to have trained there. Incredibly fantastic surgeons who were very forward-thinking and progressive. So they were always people that were willing to try new technologies. I remember, you know, using shockwave or intravascular lithotripsy, you know, in the thigh when I was like a second-year resident, third-year resident. I remember we were a site that enrolled patients in, you know, Promise, the DVA technology. So access to specialty technologies were there. And I think my interest in doing things that are unconventional, or not just PTA and bare stent, definitely came from where I trained and the people who inspired me there.
That's great. Jay, what about you? Being technology junkie, as you mentioned, I mean, compared to when you did training, let's increase it from 3 years, because 3 years is not that long, but how has it changed?
Well, no, I mean, I'm old enough, I got a lot of gray hair, I guess now, but we didn't have anything back in the day, right?
Yeah.
So we were just making up as we were going along. The BTK world, and even ATK to a point, was the Wild West. And so all we had was balloon angioplasty. And, you know, we blew up the balloon, looks kind of good, got out and moved on, right? And we now know so much more about recoil, about medial calcification, dissections, all these things. Didn't know anything about that too. So imaging is like, I think one of the biggest things has changed. And then using that information to kind of inform what kind of devices. And so we've had this arms race of lots of different technologies, some of which have really taken off, some of which have kind of faltered. You know, I used to, you know, for a while I went through that atherectomy phase that a lot of people went through. Now we know BTK atherectomy may not always be the optimal thing to do depending on the pathology. And, you know, I think imaging really has informed a lot of what we're going to do, especially with some of these vessel prep technologies.
Totally. Totally. Yeah. Speaking of imaging, tell me, like, what are you guys using for imaging? What's your typical non-invasive imaging workup for, you know, a CLTI patient that you're seeing in the hospital? What kind of imaging do you have before? And then what other adjunctive imaging, such as IVUS or anything else, are you using, Michael?
Yeah. So I think, especially in the inpatient setting, I think our emergency department, our, you know, the residents who are on call, they reflexively get CT angiography. You know, worst test to get is a unilateral CTA for a patient with bilateral wounds, but it happens. But I think CTAs happen very, very often. And I think everybody who takes care of these patients know that your ability to image and truly see what's going on in the popliteal artery and distally in the setting of CLTI, you know, is really limited. Additionally, I think we reflexively get a lot of ABIs, which, you know, obviously have a lot of shortcomings in this patient population due to the calcific burden of their tibial vessels. Oftentimes we get non-compressible ABIs where the patients have TMAs and can't get toe pressures. But that's the system within which I work. And oftentimes if a patient doesn't have a palpable pulse and they have a non-healing wound, I think the extension of your physical exam is lower extremity angiogram. And I think in the wake of best CLI, everyone was saying everyone should get a saphenous vein duplex. But oftentimes, just by looking at a patient's leg, you can assess whether or not a patient's going to have adequate saphenous vein. I think at least 50% of the time. So I'm taking these patients to the OR, our hybrid room, oftentimes with a CTA, which doesn't provide a lot of insight, and arterial non-invasives that basically cast a wide net to determine whether or not someone may heal or may not heal.
Do you find renal disease being any kind of, you know, limiting factor for getting CTAs in your population, or you don't have too much renal insufficiency?
We have a fair amount of it, but I think the quality of imaging you can get with low contrast volume CT angiography today allows you to I don't really think there are that many patients who have a CTA as a contraindication. Now, I personally don't need a CTA to take somebody to the cath lab, right? Palpable femoral pulses and a non-healing wound. I think that's all you need.
Jay, what about you?
Yeah, I mean, we have a CT scan in our office even, but I'll tell you that a lot of these patients, especially the CLI patients, they have a lot of chronic kidney disease, and you can give 100 cc's of contrast for a CT angiogram and still not see infrapalpiteal disease adequately because of the calcification. They have no idea whether the vessels are open or not. So fortunately, I think they've moved away from that in the hospital setting, but they do a lot of duplex. The problem with the duplex is that unlike our vascular lab, which is accredited, a lot of the studies that are done in the hospital I find are pretty subpar. And then they're read as, patent vessels, everything's monophasic, there's no description of anything. So already your index of suspicion is higher. And I can tell you, we can do an angiogram with very little contrast. I mean, with an endo catheter and a 3 cc syringe, you can give 50-50 contrast and do an entire angio and intervention, and with, only about 10 to 15 cc's a dye. Or you can use CO2 as well. And especially if you use anesthesia, they don't move around, you can get very good imaging. So and then you combine that with IVUS, it tells you everything you need to know. I mean, you could do the whole thing and use IVUS imaging as your adjunct to get a better sense of what's going on. Now, I'll tell you that, we use a lot of Philips IVUS as well too. It's really good. Sometimes when you get to the smaller vessels, like the tibial vessels, it's harder to see intimal plaque because of the imaging resolution. So obviously there, will be hopefully some new advances on that front as well. But I think that we have a good sense about size, and I think that's really important because one big issue in the tibial intervention space is that people tend to undersize their interventions, which can obviously lead to recoil and early failures. May have been one of the problems in some of the earlier studies that have been done with different technologies. But I think IVUS is really an important thing for all of your CLI patients, CLTI patients. You want to get an understanding of pathology and also sizing of vessels.
Question for you. Totally agree with IVUS. Now, both of you, Michael, you mentioned inpatient setting, a hospital-based, Jay, hospital too. Do things change in the outpatient setting? Say, like, do either of you work at anything like in an ASC or OBL where overhead might be a concern? I don't. My practice is hospital-based, and I can open up whatever I want, and no one's really looking at the cost at the end of the day. What about you guys?
I started in an OBL, and I was the OBL director for about 2 years before we were bought by the hospital. I've been hospital-based ever since. There's rumblings of us going back to the ASC world. So I am cognizant on the cost side of things too. The good thing is imaging, by and large, is reimbursed in the OBL world. So they've actually driven a lot of the utilization of imaging because it is favorable, at least in terms of reimbursement. So that shouldn't be a drawback, especially in your CLTI patients. Now, in terms of device choices, that could obviously get impacted. Obviously, there's a little bit more reluctance to use specialty devices because of the cost associated with it. But then I know a lot of OBL guys out there too who try to do the right thing. So in the right kind of patients, if the imaging suggests you need something more than just a straight up balloon, then they're going to pull the right device.
Or we'll get into kind of the economics too. Michael, how about you? Are you mostly, you don't have to worry about, the cost of devices that you're opening up or particularly that, or are you being monitored?
I think we talk about it a lot, and I like to think of myself as an employee of the state of Texas, like that's, I work for the state, and I want to be a good steward of our finances. But definitely beyond that, right? It's something we've increasingly started talking about in our departmental meetings, just being cognizant of the cost of the tools we have. And I think that's how you can be a responsible physician. You can be very in one of the core components of vascular surgery training, our jobs as educators for the fellows and the residents is to teach them about the cost of what we're doing and make them cognizant of that. So we try to be, but I think like you, sometimes if a case demands a lot of stuff, we'll do it.
You got your pedal and wires are not working, opening up some stuff. But no, I get it. I always think, there's two sides of a story when people talk about, atherectomy, people are overusing it because of the reimbursement. But then, you look at the other side and people using it in the hospital, and it's not really, I guess, depending upon how your contract is financially driven all the time. So, okay, let's talk about vessel characteristics. What are some characteristics of an angio that you'd see that would make you particularly maybe skip a specialty device, or something that you'll see that you're like, okay, this is going to take some time. Jay, like what are some things that you look at your angio or IVUS that's pushing you either way?
Yeah, I mean, one thing that we know is that angio can be very misleading, right? So that we don't know, especially when people that take orthogonal views. And I mean, you could sometimes see calcification, especially if you see that on your subtracted image, you just see the outline of the vessel. You know that there's going to be a lot of calcium. That's going to really kind of drive you more towards using a specialty balloon. But I think the IVUS tells you where it is. I mean, is it in the wall? Is it intimal? Where is it located? I mean, we have a complete replacement of the lumen with calcium. So that kind of stuff would drive you to use, fancier devices as well too. Maybe even fancier crossing tools even, I'll pull things out there too. I want to make sure I stay intraluminal as much as possible crossing. And then I'm going to use a better wire perhaps with a higher tip load to be able to cross. And it's all about strategizing and figuring out what you need. But, we'll know some of that before we even pull the IVUS out. And then a lot of times afterwards, the imaging will kind of drive you towards one way or the other. Hey, can I get away with just a straight balloon here? Or do I need to pull something different?
Yeah. Michael, what about you? Anything to add to that?
Yeah, I think that the first thing I do when a patient gets on the table is I take inverted images of the tibial vessels and the foot vessels just to get an idea of the severity of their underlying artery calcific burden, right? So I'm going into it, and oftentimes these patients have railroad tracks going all the way down from their popliteal artery. And in that setting, I'm very quick to think about using specialty technologies. I think it's less frequent for me to use straight up PTA than it would be for me to use something different. The big consideration I have is after I've taken my pictures and, I've decided which vessel I'm going to treat, how easy is it for me to deliver my support catheter to sort of the target we're needing to get to in order to start treating? And if I struggle in any way, shape, or form doing that, then I'm thinking specialty technologies for sure.
Okay. I like that. You take inverted like spots. So you take spots of the baloney and the foot, and then you invert them kind of like an actual radiograph.
I can't take credit for that. That's a Roberto Ferrarese move.
Yeah, I like it. I'm going to add that to my, you always have like foot radiographs from the ER because they have a wound, and you can just see those tram track calcifications or even just, interrupted calcification. It does affect how, you're going to have some really bad disease. So it's a nice like analog way of really taking a good look at those vessels.
And then, should you ever want to like go back in time and look at the MAC scores for your patients, like you're not relying on some X-ray tech's positioning of the foot. It's the imaging that you need to see everything.
Now, is there a big difference in how you approach ATK versus BTK? You have those huge chunky calcifications in your, distal fem pop, say, adductor canal, are going into the pop near the level of the knee joint. What are you doing? Is your first thought heavy calcifications? Is your first thought shockwave? Is your first thought atherectomy? Jay, what goes through your head and what's your algorithm?
Yeah, I mean, for really bulky calcium, I've moved away from atherectomy using more IVL. And I found that works, especially the combination of IVL plus a specialty balloon seems to work really well for me. I mean, there are cases where I will use tools like CSI and whatnot to orbital atherectomy, even rarely a rotational atherectomy as well too for severe calcium above the knee. But the only problem is sometimes some of those technologies bounce off the calcium. So I do like IVL for that, for those kind of nodular lesions. Especially we have some newer IVL tools coming out. There's a whole bunch of stuff coming, which is really exciting. BTK, the calcium distribution is a little bit different than what we see ATK. A lot of times you need more circumferential, more medial calcification and whatnot too. I do some IVL for that, but I tend to use more specialty balloons. And a lot of times if it's hybrid type stuff, I might even use a combination of laser as well too. But most of the time I'm using a specialty balloon in those kind of situations for the BTK disease.
Okay. Michael, what about you? I mean, I would say for shockwave has definitely been a big game changer for us for ATK in my practice. Is that similar to you?
Yeah, I think that the biggest consideration I have when I'm dealing with real eccentric boulder calcific disease of the SFA is like, I just got to get across. I think above the knee, because we have things like shockwave, because you have the ability to take really high pressure balloons to get luminal gain there, and then you have the bailout of fantastic drug-eluting technologies and implants, I think that it's easy to be really aggressive in that space. And I'd love to be true lumen in the ATK space every single time. But, when you're dealing with bulky stuff, it's sometimes hard to do. Shockwave has gotten so popular, and I use it all the time because I think I don't feel nervous taking a shockwave balloon to 4, 6, sometimes 8 atmospheres. Whereas if I'm taking a conventional balloon to 14, 16 past burst, sometimes that's harrowing.
And also and then compared to atherectomy too, I mean, the risk of embolization, it's just less on your mind.
Using atherectomy in a subintimal space, sometimes it's safe, sometimes it might not be.
Anything you do, particularly you mentioned, crossing true lumen, do you do any techniques or tips, in the ATK space to try to be true lumen, Mike? Or just wire and seeing how the wire feels?
Fadi Saab and Jihad Mustafa and the CTOP classification is something that I think about. So if a cap morphology isn't favorable and I've taken a bunch of different obliquities and I can't sort of elucidate that proximal cap very clearly, I'm super quick to just get retrograde access. Additionally, sometimes, I have to say this, I'm a surgeon, that there are situations where I think about doing a bypass.
Oh my, what?
Yes.
What?
Yes.
No.
It happens.
Yes.
And I promise you, there's situations where, maybe 3-4 years ago, I wouldn't have thought about bypass. And, I've sort of kicked myself because you have a dissection at your reentry. And now what could have been maybe a fem above knee pop or a fem BK pop is now a fem tib. And, maybe the vein is marginal now. Now I'm like, oh, I got to put PTFE there. That was a mistake. I shouldn't have done that. But I mean, sometimes the wire does what the wire wants it to do.
Sure.
Despite our best efforts. I don't have the time to pull a wire back with IVUS and go in and go out and but Jay has a lot of.
We can't be all like Jay. We can't be all he's pulling out OCT and all this stuff to getting true lumen.
Yeah, I mean, we did that for a long time. I remember back in the days of Avenger and the Ocelot and the Kitty Cat, things like that. We had all these front-facing imaging through. I mean, it was really a cool concept to try to stay intraluminal with imaging plus with crossing, but it never really took off, right? So a lot of what we do is by feel. And, you feel the cap. And then, I'm old school. I tend to do a lot of larger wires like the 035 Glabwire Vantage. And I use a lot of reflow spec catheters, really kind of help me get across these lesions. And most of the time I do fine. And I have a very low threshold like Mike to go from the foot. I mean, honestly, if after a couple minutes, I'm not crossing from above, I'm going retro as well. I mean, I'll even, porate a lesion from the outside if I have to, like we use a kind of a Pierce technique or whatnot. So I don't have his luxury of sending me for surgery. But again, we have to be cognizant of what we do so that we don't burn bridges and don't allow the patient potentially get the right type of operation ultimately done if that's what's necessary.
Totally agree. I mean, it's pretty universal for people who do a lot of endovascular work is that everyone will say they go, retrograde, they go pedal pretty quickly. And I think it's pretty old school thought now that try so long from above, or if you're doing that, then you're doing something wrong. Now we've kind of been very generic. We've been saying specialty balloons, etc. What are some devices in the BTK space that you're saying that you're now using that's kind of changing the game for you? Michael, not a balloon, but you mentioned bioresorbable stents. I agree. I've been loving these things, even though how expensive they are. They're amazing. And I've been dropping a lot of them lately. Sorry to my hospital, but they're pretty nice. What other devices are you using?
Yeah, I think Jay said it really nice at the beginning of this. It's truly, it feels like an arms race. There's so many new technologies. I mean, I've been using the Serenator balloon. It's been a huge part of my BTK practice probably for the last 5 years. Beyond that, over the course of the intervening time period, we talked a little bit about shockwave intravascular lithotripsy. Historically, the limitation was what is this called? Balloon lengths. And it was too short. Now it's slightly longer. It's 8 centimeters. In my opinion, doesn't always address everything. Jay sort of put me on to the Spur, the retrievable stent technology that just got commercial approval. We got to participate in their trial. We used it a couple of times this past week. And then One other thing that I haven't talked about yet goes back to Shockwave, the Javelin, which is like that forward emitter, sort of crossing catheter for CTOs, BTK. Those are the big things that I think about using. And now I'm trying to figure out where each of these things falls into my algorithm, which is challenging.
Yeah. I mean, so mention some devices. Jay, can you talk about what the Serenator is? What is the spur from reflow, and other things? Can you kind of describe what it is and your experience with it?
Serenator, or this so-called serration angioplasty, it's the concept of point force technology. So there's a lot of scoring technologies out there that utilize wire-based tools or whatnot to try to allow for controlled angioplasty. The problem is the force is distributed diffusely across those wires. Now, I mean, it helps prevent dissection and does help you get some luminal gain, but really it doesn't help you fully yield some of these really tough lesions. So the concepts of serration angioplasty is you have these metallic strips on the balloon, and these things come out to be up to 120 millimeters in length, which is really quite nice. And these metallic strips have tiny little points on them, so little serrations. And they're folded down when the balloon is clasped, and they expand, and you slowly engage the lesion. And what it does, it's kind of cool, is that each one of these little points, the force is focal. It's a when you talk about focal force technology, this is the ultimate focal force technology. It's about 1,000 times more powerful than traditional angioplasty. So I think that it's one of those things that if you use a traditional balloon, you don't know where the pressure is going to be distributed. I think that with this, it actually forces it right at the point of interest and then at every serration point along the length of that balloon. So it's really quite useful, ATK and BTK. Now, to contrast that to, say, something like retrievable stent technology, so the spur device is literally what it is a retrievable stent that's got an integrated balloon. It's got all these spikes on it. This device is not available for above the knee. It's only a below the knee device at this point. And they're going to be starting a trial with drug as well, too. These spikes engage into the plaque. The balloon pushes them into the plaque. And then you can deflate the balloon and allow blood to flow. So you're leaving the scaffold or stents essentially left up for a couple minutes or so. The whole process, in the trial was 6 minutes long. But then you retrieve it and you pull it out of the body, or you could use it in another area again. Some people are using it in multiple tibials at the same time. So it's a different technology. I think different purposes. We're still trying to figure out where we would use one over the other. The advantage right now, I think, with the Serenator is really long links, and then they also have an ultra low profile, their SL Pro, which is like 2 millimeters in size. You can get that all the way down to the foot. With the Serenator, I think we have kind of a broader matrix. Spur right now, too, we're more limited on sizes. There will be more sizes coming down the road, but the commercial launch is kind of smaller links at this point.
Really good descriptions, and I've had some experience with Serenator kind of in the beginning. Michael, what would you say, like, from the crossing profile of these devices? Are they, compared to a POBA balloon, how much bigger are they? Do you have difficulty delivering it down to a distal tibial or below the ankle?
Yeah, so I mean, the way I think about this, short answer is yes, they are bigger than a regular balloon. But the expectation that we have in using these specialty technologies is your patients are going to get more from them. So it makes sense that they might be a little bit more challenging to deliver. Historically, I'd say 4 years ago, I was using a lot of orbital atherectomy for my tibial cases. And I found that using a micro device, passing it just a couple of times just to make a pilot channel would facilitate delivery of any of these technologies, whether it was Serenator or Shockwave or anything like that. And I've continued to see that. Although I don't do as much atherectomy as I may have in the past, I think a little predil. Most of the time, all of these get a predil with a 2.0, just regular PTA balloon, taking the low pressure up and down just to make that pilot channel. And I don't really have any issue. And you're absolutely right. Serenator can get delivered all the way down to below the ankle. I'm really looking forward to Ted Gifford's paper getting published looking at the results of specialty balloon using the Serenator for the treatment of BTA arteries.
Nice. Yeah, exactly. I mean, it's funny. It's a little bit like you need a vessel prep for the vessel prep.
You have to pave the road.
You have to pay a little vessel prep for vessel prep. and then a final delivery, but it's true. That was my experience early on, which kind of hindered us in my lab a little bit, is my patient population, diabetics, really shitty tibials, subtotal occlusions, etc. Like trying to get even sometimes just getting a regular balloon across was really hard, right? And then we kind of had to prep and then to get another device. But I know, Jay, you mentioned that they have a more smaller, lower profile version now. And again, those all come, the max length is 120, right? That's good.
I've been using that a lot more now too, especially for a lot of our BTA type stuff too. I'll tell you that you can use that very commonly without any type of pre-ballooning. That was always the Achilles heel before too. Like you said, you got to prep and, it just slows you down. And even with the retrievable stent technology, they had recommended ballooning first as part of the IFU before delivering the device. So, ultimately, as these devices keep getting developed and iterated, ideally we want to get more efficient so we can cut down the number of steps that we have to do and to get these cases. I mean, they're long cases to begin with. So the last thing we want to do is use a ton of product.
The retrievable stent's a very interesting concept too. So the balloon goes up, then the scaffold or those spikes stay up. How do the spikes come down?
Yeah, so when you resheath the stent, the spikes collapse back down. And so then essentially when you unsheath it, the spikes go up and then the balloon engages it. But when you pull the sheath back over, it collapses them down, and then you could redo it essentially at that point anywhere else you want to try to take it. I mean, it's great. I mean, they'll also eventually have low profile versions too, but it's definitely a lot bulkier than some of the other specialty balloons.
I can imagine.
Yeah. So
the crossing and any issues ever resheathing the stent, like it gets kind of stuck and you can't pulling a little bit, or no?
Yeah. So the thing is, if you were to pull backwards, the spikes would disengage, so because they're kind of exactly, it's the path of least resistance is pulling back. So really in the trial there was no situations where the device got stuck or anything like that too. So I mean, that's always the fear with any of these devices too. You really get, you have this really chunky calcium, your device kind of gets stuck, even regular balloons, and then you kind of inflate it, deflate it, try to move or wiggle it around a little bit too and try to get it out. It's just, these are tough patients.
Your balloon ever rupture while you're putting up the spikes?
In the trial, I think it's extremely rarely. I know of one case that happened in their commercial experience where they had that happen and they had to pull a second device. But, it's not something, probably what it was is like a spicula calcium that came through the side struts.
Right?
I mean, it's going to happen. I mean, that's the reality.
Yeah,
right?
I think like the one guiding piece of evidence that we have for all these specialty technologies, is their principal studies have all demonstrated that they're all safe, right? They're all safe. And the hesitancy that most people have when they put something new in their hands, the serenator, the metallic strips, the concern that what if this is in a subintimal space? Is it going to perforate the artery? Or, when you look at the spur in and of itself, it almost looks like a medieval weapon or torture device.
Gladiator. Yeah.
Over and over, we've seen that these technologies are first and foremost safe for our patients.
The difference with serration angioplasty is you don't really need to go to high atmospheres, right? So the balloon itself too, you can do very low atmospheres, like 5-6 atmospheres, and really get good luminal gain. And I mean, most people don't need to max it out at 10 atmospheres. So it's a low pressure angioplasty, and the serration is doing the work, right? That's all that point force is being applied across the lesion. So I think that's important to understand that, we're not trying to do high pressure angioplasty. You get a balloon rupture, then you end up with a perforation.
Yeah. Is there any kind of, I know it's nitty gritty, but like the technique of inflating it, are you like taking it 1 atmosphere, waiting to see some waste resolve and going real slow up to that 5? Or is there anything in particular you kind of learned about inflating the serenator or the spur, Jay and Mike?
Yeah, I mean, you're low and slow, right? We forgot how to do angioplasty because people wanted to go so quick and ended up ripping up all these vessels, right? So just think about it like, silly putty, you're slowly stretching these vessels, you're yielding these lesions. Give it time to actually engage and create those microfractures, and then you can avoid tearing the whole vessel up. So, serration and retrievable stent technology are kind of very different in terms of the workflow, right? So with serration angioplasty, low, slow, gently inflate it, you take it up to your target, when you see the waste is gone, and then you leave it up maybe for a couple minutes, 2-3 minutes, and then do whatever you're going to do. With retrievable stent technology, I mean, the way the protocol was in the trial is that you would go up, and then for a couple of minutes with the balloon inflated, the spikes exposed and stent expanded, you would go down for 3 minutes, letting the blood flow with the spikes and stent expanded, and then you go back up again with the balloon for 1 more minute. And where that all comes from is from what happened to the Saval trial with the PTA arm, where it was like 6-minute long angioplasty, did amazingly well. And so that's where that 6-minute number comes from. I think in the future, they'll try to cut those things down, but we know that
that's a lot of time.
It's a lot of time, and you have a short stent.
Yeah. So, I mean, in multiple stations,
Yeah. You can imagine that's going to take a bit of time. So people aren't going to do that in the real world. But same thing with serration angioplasty. I mean, I tend to leave it up for a couple minutes. Mike, I don't know, how about you? Like, in terms of how long you leave it up for?
Yeah, so I oversize all my balloons for the BTK space, especially when I'm using these specialty technologies, because like Jay said, you're relying on the technology and not necessarily the balloon to get you luminal gain.
How much oversizing?
So I'm doing it 1.1, 1.2. I think that's how I approach all my specialty balloons. And when it comes to duration of inflation, it's, minimum 2 minutes, in general 3. And the way I inflate balloons is I'm not looking down, I'm looking up at the screen, and I'm seeing, after prepping the balloon, I'm seeing how the balloon responds to the lesion. And I'm not looking for parallel lines of my balloon, quickly. I'd rather see that at the end of my angioplasty as opposed to at the very beginning. So 2 atmospheres, wait 30 seconds, step on flow, take it to 3, 4, maybe take it to 5, 6, but I'm generally not taking the Serenator 6 atmospheres.
No, that's also a really good point. Whenever I have someone new doing an angioplasty, I'm like, don't look at the inflator, look at the screen. And it's just like a very little simple thing that comes naturally to us. But when someone's first starting, they don't really know. Following the specialty angioplasty, you serenate the plaque, or are you spur? Are you following it with a POBA, following that? Or can you leave it as is?
You could leave it as is if that was just the focal lesion. So, for example, if you had a lesion that falls within the length of the serenator, you could theoretically just leave it up for 3-4 minutes. Longer is always better. We know that from multiple studies, obviously. So, but usually I do tend to use, if I do serration angioplasty along a length of a lesion, then I might use a long POBA balloon to follow as well too, to kind of really just do another 3-minute inflation. So in all, it ends up being about 5 to almost 6 minutes of angioplasty. For me, I found gets me really good results. I mean, now when one day we have a drug-coated or drug-eluting balloon that we can use BTK in the United States, then we'll probably skip that step and do that instead. I mean, I really believe serration angioplasty is going to allow for better drug uptake. Spur probably will too. We're going to be studying that in the trial. Yeah, I mean, I'm waiting for one of the Limus options to become available commercially.
Yeah, Michael, you were saying you don't typically. I saw you don't typically.
No, I think that sometimes, depending on how long a fellow or a resident has been on my service, we'll do a post-interventional IVUS. And, after doing hundreds of these cases, I haven't really seen anything that really needs to get ironed out. But like Jay, I'm waiting for the day we can treat these patients chemically in addition to the mechanical therapy that we're able to do right now.
Jay, I know this is a little off topic, but, you mentioned Limus, and Limus has been, very, standard of care in the coronary space with coronary stents. This is off track, but why is Limus, do you think, going to be better in the BTK space as opposed to our negative trials with Taxol?
I mean, this is a complicated thing, but...
Yeah, I know. That's why I was like, oh, where am I going with this?
And there are a couple companies that are going to stick it out with paclitaxel BTK. And, I think that we could talk about why we thought that the other trials failed. And that may have to do with vessel prep, may have to do with how we were approaching BTK lesions. But Limus, by and large, has a very broad therapeutic window. So you could really max out the drug. There's no such thing as too much Limus. There is such thing as too much paclitaxel. And then the other thing too, but that's more of a drawback, is how do you get it there? So paclitaxel, works on contact, And so if you've done some angioplasty or whatever, the paclitaxel should be able to get in a little bit better. But with limus, you're going to need some nanoparticles or some microspheres or a way to actually get that limus to hang around, get into the tissue, and then get it to hang around. So getting past that surface intimal calcium is going to be really important. That's why serration angioplasty, spur, other technologies are going to be really important to be able to get it to where it needs to go. Otherwise, the drugs are going to all fail. And that's probably one of the reasons why the other trials weren't as successful.
Yeah. Okay. No, that's that. I always tried to wonder that question, like, because I do feel that limus is going to be a really great addition to our BTK space based on our.
But it's an uphill battle. I mean, it's really hard to do it.
Yeah. I mean, the coronary stents that we're putting, how are they delivering the limus then through? I mean, they're not using nanoparticles and stuff.
No, but the difference is that they elute over time. Remember, you're leaving a durable scaffold behind that can continue to slowly elute. So the difference is with a retrievable scaffold or no scaffold, you then just have to leave it and then you take it away.
To get in there.
Right. So the difference is like with bioresorbable scaffolds, they do continue to elute over time, but then the scaffold melts away. R3 has got their trial going on right now. They're going to have long length scaffolds that are resorbable as well. We'll see if that strategy works. And we have to hopefully make sure that they actually stay open, unlike, what happened with Saval, which was a durable scaffold that eluted paclitaxel. And it failed for multiple reasons. I mean, there were cases of thrombosis, cases where you had early failures with that long scaffold. So, I'm not sure about durable scaffolds, long length BTK. We know the coronary stents work in a very small segment of the tibials, but, a long metallic scaffold could be problematic.
Mike, I mean, you talked about being cost conscious earlier. Now we're talking about some crazy stuff, retrievable stents, Serinator. These devices, long bioresorbable scaffold, I mean, the 38 millimeter length costs $3,000. I don't know what a 100 millimeter length scaffold will cost. But what do we do now in these settings where one side is the cost is going up and the reimbursement, and then also the cost of the patient and the system? Where are we going with that?
Well, I think that when you look at long-term treatment of these types of patients with critical limb, right, there's a tremendous amount of cost, maybe in the upfront case, but certainly with reinterventions, that's another nidus or burden on the healthcare system. So I think it's easy to justify using these specialty technologies if they work better, the historical alternatives, and the patients are going to tolerate these procedures. I think one of the things that vascular surgeons say all the time is like, well, nothing works as good as a bypass with vein. That doesn't necessarily take into consideration who the patient is in front of you. Not every patient's a candidate for a vein bypass, and arguably a vein bypass done well might be the cheapest thing for these patients. So when I think about using these specialty technologies, whether they're longer scaffolds that are going to cost more money, intravascular lithotripsy, things like serration angioplasty, certain things cost more than other things. A serration angioplasty balloon is cheaper than a stent. It's cheaper than an IVL balloon. It's cheaper than a retrievable scaffold, right? So if we're being considerate of cost, I think that this is a fantastic tool to achieve excellent outcomes for your patients. But at the same time, when we do have more expensive things, right? If you spend the money up front to get your patients the most durable result, one, these patients aren't going to need reintervention, and two, these patients will go on to do well, and I think it's better for their quality of life and overall what we're trying to achieve as physicians taking care of patients.
Those are excellent points, and something, that's very difficult to explain at like a VAC committee or a VAT committee saying like, I want this $1,000 balloon, but it reimburses as a POBA. Jay, how do you approach that challenge with hospital committees or anything else to get some of these devices approved?
Yeah, I mean, this is the real ultimate challenge for every company that's working in the BTK space, is to try to achieve a higher level reimbursement beyond just POBA alone. Retrievable stent technology, it reimburses as a stent, so that's a little better than doing POBA, so that's good. Obviously, the IVL space, they're actively pushing for reimbursement, BTK, and I think they have certain codes that it's intermittently reimbursed, and we'll see what happens in the future. But I think with a lot of push, it will come. I think serration angioplasty is the same thing as well too. Like, you have to ultimately understand that these things are doing something different than beyond POBA alone. So there's pushing the payers to kind of recognize that, say, hey, our outcomes are better than what we're doing regularly, and it probably warrants a higher degree of reimbursement. That's a long-term play. At the VAC committee level, this is where we have a partnership with them too, and some hospitals better than others. If I tell you that I'm going to be able to reduce the number of times I re-intervene on this patient, or I'm going to reduce amputations, which are a massive cost to the system, then, sometimes what they'll do is they'll test it out, they'll follow the patients. And that's how we've been able to get some of these newer technologies in is, we trial them, we see how they do. They see how the reimbursement falls and how the patient does over like a 90-day global period. So it's definitely becoming a challenge. All these companies want us to get their products approved. It's not so easy nowadays as it was in the past, but it really is kind of like pushing that idea that, hey, this is better than what we've been doing. And in the long run, it's going to save you money.
Yeah. And that whole trial thing, that's kind of my secret weapon with the VAC committees. I just kind of, I get a device in there saying, let's see how it performs for 6 months.
Let's do 5 patients. So we'll see how it goes,
And then they usually forget about it. I hope my hospital doesn't listen to this, but that's my secret. That was a lot of information. I mean, any kind of, we mentioned these, I know we didn't really go into atherectomy. That topic's been really done and done like so much, but I really wanted to talk about these specialty devices, the 2 of which we really touched on. Any other, things that down the road or any other devices that either of you can talk about that you've got your hands on about vessel prep?
I can say that, a recent acquisition by Boston with Bolt, I mean, that's a laser IVL technology. They're going to have, hopefully long links. And so that'll be another IVL tool that's going to be out there as well for both coronary and peripheral applications. There's like 8 IVL companies out there, all who have different mousetraps as well too.
After the $13 billion acquisition there.
Exactly.
It's a nice space to be in.
Well, it's just kind of like the thrombectomy world. People are just like, now this is their next thing, and there'll be something else. But BTK is like the Wild West, and everyone knows we're doing a bad job, but we need to do better. So I think I'm excited that they're investing more in this space. And, the long link resorbable scaffolds, I mean, R3 is going to be very interesting to me, I think, to see if that works, if that's successful. And also I'm interested, in potential newer applications of serration angioplasty, especially with drug, retrievable stent technology with drug. I mean, these are all things that are potentially coming. We just have to make a value argument for it.
I remember, is that, I think Fatty would show sometimes online, like, I think it must be the Recor where you can inject drug through the spikes or something.
No, that's a bullfrog device. No, that's
bullfrog. What is that?
Mercator, yeah. So they pivoted. Now they're actually in the venous space. So that was a balloon.
They're in the arterial space too. They're actively conducting another tibial trial.
Yeah, another trial. Yeah. They've been at it for a long time. They had a single spike that you could inject a physician-specified therapeutics. Usually at this point it was dexamethasone. When they first started, they were doing things like paclitaxel. But yeah, in the arterial space, they've been at it for a while. But the venous stuff, they're in the dexterity AFB trials. They're looking at reducing rethrombosis post-venous thrombectomy and DVT to see if that might actually help, because rethrombosis is a major issue in that space. But the spikes that are on the spur are not hollow, they're solid. So in the drug version, the balloon will be coated and the spikes will be coated, and then those will be infused or injected into the medial adventitial space. The idea of bullfrog and 102 is still very interesting. I think the challenge becomes like, what drug do you use? And I think, Mike can correct me if I'm wrong, I think they're still using steroids.
The trial they're doing right now is a limus-based.
It is limus-based. Okay, good, yeah. Good. That's what we had asked for years ago. So it's like, because they were having us try to use paclitaxel back in the day. So, but that's cool. I mean, that if you can show that it distributes evenly in that medial periadventitial space as well too, that might work really well. Then you just have to get it to stay there. Mike, do they have like a nanoparticle or anything like that to keep it around? Or, how do you prevent it from infusing away?
I think it's just because you're injecting it, when you inject it correctly, you're injecting it inside the vessel wall, you're sequentially injecting it along the length of your treatment area, right? So you're not necessarily injecting it in a place where it can necessarily move if done correctly. Obviously, if there's too much calcium and the needle can't penetrate into the wall, you're going to see that contrast and drug go downstream, right? Which is,
Yeah.
ineffective.
Yeah, because they mix the contrast with the drug, right? When they're injecting.
They have like essentially a pneumatic pump that you use to put small amounts of the drug into the wall.
The big challenge with limus is we're talking about, it's got a broad therapeutic window, but the problem is getting it to stay where you need it to stay and not just diffuse away into the reticular endothelial system, right? So the thing is, it goes to the vasa vasorum, then it disappears, right? So you want it to kind of hang around. So you typically need some kind of particle or something you encapsulate the limus in so that it hangs around and doesn't just disappear. Paclitaxel you could do that with because it's cytotoxic. It's directly on contact. So if you inject paclitaxel, it just kills things immediately. But with limus, it's a slow effect over time. So I'm curious how they did it or how that's going to go.
I mean, it's fun to see all this innovation and everything. I mean, we touched a little bit about how, this all adds time to a procedure. You do all of these interventions to the tibial and then adding all this. I mean, we're going to have to kind of figure out as we go on how to kind of optimize. I mean, adding so much more time to a case can be kind of hard if you have a busy day too, but the outcomes definitely outweigh, some of that. But it can be hard in a busy practice and whatnot. But yeah, I mean, that was a lot of really great info, guys. Any kind of last words of wisdom or people who are, maybe companies that are coming out with some devices, any kind of words of advice to our audience?
Well, it's not necessarily advice, but take this opportunity to build on what you just said. It's the data that we have to generate that's going to help propel this field forward. It's going to justify using these specialty technologies. And, we haven't said it yet, but Jay and I are co-PIs for a prospective registry looking at serration angioplasty, the point force registry. Things like this, whether it's serration angioplasty or any of the other technologies that are coming down the line that Jay talked about, like these are the things that we have to do because we have to be physician scientists. We have to do the research. We have to be dedicated to changing the way therapies are delivered and which therapies are delivered. And I think that this is a great opportunity to talk about the work that we're doing, Jay, and, super proud to be doing it with you, someone I admire, with a company that I think is doing great things. Oh, man. But yeah. I'm looking forward to getting the patients we need in this trial and seeing how everything sort of shakes out.
And stuff like this is really exciting as well, too. So I encourage everyone to kind of listen in on these kind of podcasts. Honestly, I started doing BTK serration angioplasty because of Mike. So I saw his cases, especially below the ankle as well, too, because I think he had some of the early experiences with it, too. And I was like very skeptical. I was like, hey, can I get it there? And, I tried it out. I was like, hey, this actually works really well. Kudos to you and the great work you're doing. I would just tell folks kind of as a parting comment that, balloon angioplasty alone is not enough. I mean, we got to do better. And we know that like a lot of times we're undersizing our treatments, the vessel recoils ends up looking just the same as when we started or worse. So we got to find ways to do better for our CLTI patients. And, I look forward to these kind of technologies to helping us do that.
Well, thanks, guys. That was really informative. I'm looking forward to, the next, we talked about what changed in the last 3 years, what's going to change in the next 3 years from now and beyond that. So thank you, Jay. Thanks, Mike, for being on. Aaron, our sound engineer, thank you for making us sound pretty good today on this podcast. And I encourage all of our listeners, if you have any questions, please reach out to any of us. Jay and Mike are really great and approachable. So just ask us any questions. We're happy to answer them. Thank you, guys. Thanks for being on, and see you next time.
Thanks a lot.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabeen Dhand, and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.